There's a document the United States military spent 20 years writing in blood. It's called the Committee on Tactical Combat Casualty Care Guidelines. And almost nothing in it is about combat. It's about the three ways people die before they reach a hospital when the system around them fails: uncontrolled bleeding, a blocked airway, and air trapped in the wrong side of the chest. That's it. Those are the three. And every one of them can be reversed by a person with 15 minutes of the right training and the right gear. I'm Doc Marco, and this is Talking TACMED, Episode 1. So here's the problem I want to name in the first 10 minutes of this show existing. Tactical medicine has a brand problem. When a civilian hears the phrase, they picture soldiers in body armor. They picture something that does not apply to them. And that perception is the single biggest reason preventable deaths keep happening in places like grocery store parking lots, at youth soccer games, and in the first 3 minutes of a highway accident on 995. This episode is for anyone who has ever thought, hey, that's not my job. It's for the parent, the teacher, the small business owner, the off-duty nurse, the guy who just happens to be the closest person when something goes wrong. And the specific failure mode I'm going to fix today is the belief that tactical medicine is for tactical people. It's not. The physiology does not care what you do for a living. So let me walk you through the three categories of preventable death, because if you understand the mechanism, the gear, and the doctrine fall out naturally. 1, massive hemorrhage. The average adult carries about 5 liters of blood, give or take. You can lose roughly 30% of that volume before your body can no longer compensate. That's 1.5 liters from a severed femoral artery, the big one that runs down the inside of your thigh. You can reach that threshold in under 3 minutes. Not 10, not 6, 3. Number 2, airway compromise. The brain starts taking damage at about 4 minutes or so without oxygen. Irreversible damage begins at 6. An unconscious person lying on their back with their tongue falling back into the airway can reach 4 minutes in a crowd of people doing absolutely nothing wrong. They just don't know that the simple act of rolling that person onto their side is in fact a medical intervention. Number 3, tension pneumothorax. A penetrating chest wound, knife, bullet, piece of windshield can create a one-way valve where air enters the chest cavity but cannot leave. Pressure builds. The heart gets compressed. Cardiac output falls off a cliff. This one kills in about 10 to 15 minutes, and it is the single most under-recognized cause of preventable death at scenes of violent trauma. Those 3, hemorrhage, airway, chest, that's the entire pre-hospital lethal triad. If you can recognize them and do one correct thing for each, you have just become the most valuable person on that scene. Now, let me tell you where this comes from, because I want you to know this is not my opinion. The Committee on Tactical Combat Casualty Care, we call it COTC, is a group of military medical officers, trauma surgeons, and operational medics that has been continuously revising battlefield trauma guidelines since 1996. Their recommendations are what drive the training of every special operations medic, every combat medic, and now, because the data is so overwhelming, every major civilian EMS system in the United States. COTC gave us an algorithm called MARCH, M-A-R-C-H, massive hemorrhage, airway, respiration, circulation, head injury, and hypothermia. Now, I want to be very specific about something here, because this is where civilian first aid courses get it wrong. The order is not arbitrary. It's not alphabetical. It's not just what's easy to remember. The order is a priority hierarchy that reflects time to death. You don't get to airway until you have controlled massive hemorrhage, because a perfect airway on an exsanguinated patient is still a dead patient. And the civilian instinct, the instinct that has been trained into us by 30 years of CPR first messaging, is to go to breathing first. That instinct, in the presence of uncontrolled arterial bleeding, will kill the person you are trying to save. So the doctrine is this: M before A, always. Stop the bleeding first, then open the airway, then assess breathing, then look for circulation problems like a second chest wound, then address head injury and hypothermia last. That is not a checklist. That is a triage of time. Let me put you in a scene. You are at a youth soccer tournament on a Saturday morning. Two cars collide in the parking lot, maybe 35 miles an hour. Nobody has their seatbelt on because they were pulling into a parking space. One driver gets out and is walking around. The other one is slumped over the steering wheel, and there's a spider web crack in the windshield above their head. So, what does March tell you to do in order in the next 90 seconds? M, massive hemorrhage. You approach, you do a visual sweep, the ground, the seat, the person's clothing. You're looking for pooling of blood or soaked fabric. If you see arterial bleeding from an extremity, that is your first problem to solve, and nothing else happens until it's solved. Direct pressure, tourniquet, high and tight. If the wound is on an arm or a leg, that is the answer. Then we move on to A, airway. If there's no massive bleed, now you can check the airway. Is the person breathing? Is their head in a position where the tongue to be blocking the airway? If they are unconscious and breathing, a simple jaw thrust without moving the neck can be life-saving. If they're not breathing at all, you have a much bigger problem, and you are now calling 911 and possibly even starting compressions. Moving on to respiration. If they're breathing, but is it labored? Are they sucking air through a wound in the chest that you can see? Listen for the sound. If there's a penetrating chest wound, that is a chest seal problem. And if you don't have one, an improvised occlusive dressing, a driver's license, a piece of plastic, anything is better than nothing. Once you've got that taken care of, we're moving on to C, circulation. At this point, you're looking for signs of shock, pale, clammy, confused, fast heart rate, slow capillary refill. If any of these are present, you are keeping them warm and flat, and you're making sure help is on the way. Finally, we'll address H, head injury and hypothermia. That spider web crack in the windshield means a head strike. So you do not move the neck. You keep them nice and warm, because trauma patients cool fast, and hypothermia worsens bleeding through a mechanism called the lethal triad: hypothermia, acidosis, and coagulopathy. Keeping them warm is a medical intervention. It's not just comfort. That is 90 seconds of decision making. That is what tactical medicine actually looks like when a civilian does it right. So what are the three takeaways from this episode? 1, the three categories of preventable death are hemorrhage, airway, and tension pneumothorax. Every other preventable death in the pre-hospital window is a variation on those three. 2, March is a priority hierarchy, not a checklist. M before A, always. The bleeding gets fixed first, because a perfect airway on a bled out patient is still a dead patient. 3, tactical medicine is not about tactics. It's about the physiology of what kills people before they reach a hospital. That physiology does not care what you do for a living, which means this job, this specific job of being the person who does the right thing in the first 3 minutes, is available to anyone willing to learn it. If you want to go deeper, I built a 1-page scene size of PDF that walks exactly through what I just described in a format you can laminate and keep in your car. It's free. You can get it at tactical-medicine.com/brief. That is tactical-medicine.com/brief. Now, in the next episode, we're going to talk about the first 90 seconds and why most civilians freeze. Not about courage. It's about specific neurochemical event. And once you understand it, you can train around it. I'm Marco, and this has been Talking TACMED. Stay ready.